Hello everyone. In this class, we are going to discuss about the case histories which are related to disorders of blood. The first case is a female aged 58 years old comes to the OPD with complaints of intermittent soreness of the tongue, periodic diarrhea. In addition to fatigue, there is a breathlessness, anorexia, and tingling and numbness. On examination, skin and mucous membrane is pale, tongue is red and ulcerated, spleen is not palpable, pulse is 100 per minute, and blood pressure is around 110 by 78. By this history, you can come to know that the person is suffering from the anemia because there are symptoms of fatigue and breathlessness, anorexia, and this anemia probably it is a nutritional where there is a vitamin B12 deficiency because the person is having periodic diarrhea uh, and ulceration over the tongue. Okay, so that occurs because of the deficiency of vitamin B12, and also the skin mucous membrane is pale, that tells towards there is reduced hemoglobin and there is a anemia, and spleen is not palpable, probably the cause of uh, the anemia is not related to uh, hemolysis, and increase in the pulse rate and the decrease in the blood pressure, I mean it tells about the hyperdynamic circulation. So then on investigation there was a histamine fast chlorohydria, uh, which is usually a feature of uh, pernicious anemia, and RBC count is 1 million. The RBCs are irregular in size and shape. Peripheral blood smear, there is occasional nucleated RBC that indicates that there is a rapid synthesis of RBCs happening, and the MCV, uh, the size of the mean corpuscular volume has increased. That suggests about the macrocytic anemia. The MCH and MCHC mean corpuscular hemoglobin concentration, they are normal, and based on these investigation, the person is suffering from macrocytic anemia. The probable cause would be, the vitamin B12 deficiency, and the important thing is the person is having uh, fast chlorohydria. That means there is involvement of the parietal cells, which are not producing intrinsic factor of the castle, and that is why vitamin B12 probably is not is properly absorbed. Okay, so this is probably a case of vitamin B12 deficiency, macrocytic anemia, and it is a pernicious anemia. Okay, so a pernicious anemia is a vitamin B12 deficiency which occurs uh, because it is an autoimmune disorder where the antibodies are formed against the parietal cells and parietal cells are destroyed. So there will be a reduced secretion of HCl from the parietal cells as well as the intrinsic factor, so which is causing vitamin B12 deficiency. So here uh, the questions are, what is the type of anemia in this patient? Okay, probably it's they're asking about the morphological type. Okay, so it's a macrocytic anemia. What is the most probable cause of anemia in this patient? The the cause of the anemia, that is macrocytosis, is probably vitamin B12 deficiency. It can also happen in folic acid deficiency, but here the cause for anemia is the pernicious anemia, which is autoimmune disorder, which has led to the vitamin B12 deficiency. What are the principles involved in the treatment of patient? Okay, so here, since there is a deficiency of intrinsic factor of castle, if you give vitamin B12 orally, probably it won't be absorbed. So that is why the vitamin B12 has to be given parenteral route, that is IV route. So that is the principle involved in in the treatment of this particular patient. Okay, so based on the cell size, the anemia can be, or morphologically, it can be classified as a microcytic anemia, normocytic anemia, or macrocytic anemia. So important causes for microcytic anemia are iron deficiency anemia, thalassemias, and sideroblastic anemia, and the chronic diseases. Whereas normocytic anemia is caused by acute blood loss and infection, collagen diseases, malignancy, endocrine diseases. And whereas macrocytic anemia, where the MCV is more than 96 uh, femtoliters, it will be caused by the deficiencies of vitamin B12 or folate. It can be seen in alcoholism, or it can be a manifestation of a liver disease. Another case where a 40-year-old field working woman comes to a OPD with the complaints of excessive tiredness, exertional breathlessness, and anorexia. Uh, Probably this is another case of anemia, because there is excessive tiredness and exertional breathlessness and anorexia. On examination, skin and mucous membrane pale, uh, conjunctiva is severe pallor, the nails are spooning, and spleen is not palpable. Okay? And these findings suggest that probably the person is suffering from the iron deficiency anemia, because the spooning of the nail is very characteristic of iron deficiency, and impalpable spleen suggests about probably the anemia is due to the nutritional deficiency and not uh, the hemolytic disease. Whereas pulse is 100 per minute and blood pressure is 110 by 78 suggests the hyperdynamic circulation. Upon investigation, hemoglobin was 6%, 6 gram percent. RBC count is 1.2 million, which is less. Uh, the RBC, there is a central pallor, suggests anemia. Peripheral blood smear shows microcytic anemia, and microcytic RBCs, they are very characteristic of iron deficiency. Some of the red blood indices where MCV is 59 cubic microns, so which suggests again the microcytosis. The MCH and MCHC, they're quite normal, and stool examination shows the presence of hookworm. Okay, and the anemia here in this case, probably it is caused by the hookworm infestation, where it has caused the iron deficiency, and that is why the person is suffering from the microcytic anemia. So, so here, what is the type of anemia is? It is a microcytic anemia. Uh, the most, what is the most probable cause for anemia in this patient is, as we discussed, it is because of the hookworm infestation, which has led to the iron, which has led to the microcytic uh, anemia. Okay. And what is the principle involved in the treatment of the patient? Okay. So the patient has to be, I mean, uh, treated for the cause. Actually, the hookworm is infestation is causing here anemia, so hookworm infestation should be treated early, and then the anemia should be corrected with the iron supplements. Then the third case is a 8-year female child comes to OPD with a history of repeated blood transfusion and history of similar episodes in the sibling. Okay, so that suggests the presence of some uh, hemolytic disorder, genetic hemolytic disorder. On examination, the skin and mucous membrane is pale, that is, there is a anemia. Conjunctiva is severe pallor, so there is a edema also, and spleen is palpable. Okay, so spleen here it is palpable uh, because of the excessive destruction of the RBC which is occurring in the spleen. Okay, and pulse is around 120 per minute, so which is again telling about the hemodynamic hyperdynamic circulation. So upon investigation, hemoglobin is very less, that is 4 gram percent. RBC count is less. Uh, there is a central pallor and anisocytosis, that is variation in the cell size. Peripheral smear is microcytic RBCs. The MCV is less, that is 52 cubic microns. MCH and MCHC, they are quite normal, within the normal range. Okay, so in this case, here the person is suffering from uh, hemolytic disorder, and the probable diagnosis is the hemolytic disorder, and the person is receiving frequent transfusion, and the most common cause for the frequent transfusion where the transfusion is required is thalassemias, and the probable diagnosis will be the beta thalassemia, which is a more common thalassemia. What is the most probable cause of anemia in this patient? Okay, so anemia is caused by the destruction of the RBCs. Okay, where in thalassemia there will be absence of particular type of chain, alpha or beta. It causes the precipitation of the normal chain, so that causes the hemolysis, and that leads to anemia. What are the principles involved in the treatment of this patient? Okay, so the abnormal the RBCs should be replaced, and the only treatment here is the replacement of the blood with a normal blood. Okay, so that means it requires blood transfusion. Okay, so these are the some of the symptoms of thalassemia: feeling tired, pale skin. Uh, the yellowish skin occurs because of the excessive hemolysis. There can be bony deformities. There can be they can be associated with heart problems. There is an enlarged spleen because of the excessive hemolysis, which can occur in spleen. Okay. And they are susceptible to the infection because of the repeated blood transfusion, and there can be stunted growth or slow growth rates are seen in them. Beta thalassemia is a failure to synthesize beta chain, so which is more common. There is excess of alpha chain production that damages the red cell precursors and red cells. So there are many homozygous and heterozygous and major and minor forms of this disease. Anemia of alpha thalassemia is more hemolytic than dyserythropoietic. The thalassemias are diagnosed by the hemoglobin electrophoresis, the demonstration of HPH inclusion in the absence of sufficient alpha chains. The excess beta or gamma chains aggregate to form HPH, okay, and the demonstration of these are diagnostic of thalassemias. Another case, a male child, 3 years old, brought with the complaints of bleeding from the nose, mouth, urinary tract, alimentary tract, and skin after trivial injury. Sometimes a swelling of the joints with pain and fever was also noticed. The bleeding was not profuse, but it was persistent. The family history revealed similar bleeding tendency in male relatives. So all this history suggestive of hemorrhagic disorder, and more common hemorrhagic disorder is a hemophilia. Okay. So obviously, because of the absence of clotting factor 8, there is excessive bleeding because of the coagulation failure and the different parts of the body after trivial injury. Upon investigation, you can see the bleeding time is normal, and the clotting time has increased. Prothrombin is also normal. Platelet count is also almost normal. So the most likely diagnosis is a hemorrhagic disorder, one of the clotting factor deficiency. Probably that clotting factor is 8, and the probable diagnosis is hemophilia A. Why females are not affected by this bleeding disorder? And also Uh, if you see the history, the male patient is affected, and also one of the sibling is also affected. Okay, so these hemophilia, it runs uh, in male because of the autosomal recessive disorder, and females are, they are the carriers. Okay, so since it is a X-linked recessive disorder, what is the physiological basis for the treatment of this disorder? Okay, so here the clotting factor which is deficient, that has to be supplemented through the cryoprecipitate or fresh frozen plasma, so which contains the factor 8. So this is how, I mean, one should differentiate the disorders which are related to coagulation with the disorders of platelets. Okay, so the Pettica's very characteristics of the platelet disorder or vessel disorder, where the superficial ecchymosis are seen in platelet disorders. Uh, the the bleeding from is minimal with disorders of coagulation, but they are persistent and profuse in platelet or vascular disorders. Okay, so delayed bleeding is common in disorders of coagulation, but it is rare in case of platelet disorders. Deep dissecting hematomas are very characteristic of disorders of coagulation. Hemarthrosis, they're very characteristic of disorders of coagulation. Okay, so this is how, I mean, clinically, the disorders of coagulation and the disorders of platelets or vessel wall has to be differentiated. Okay. So another disease is a von Willebrand's disease, which occurs because of the deficiency of the van Willebrand's factor. Von Willebrand's factor is going to uh, helps initially in the attachment of platelet to the collagen. Okay, so deficiency of which it can lead to a bleeding disorder. That is, the temporary platelet plug is not formed, so that is why characteristically bleeding time is going to be prolonged in von Willebrand's disorder. Okay, so since von Willebrand factor carries the factor 8 also, the severe diseases, they also manifest with the deficiency of factor 8 also. So as the severity of the van Willebrand's disease progresses gradually, the clotting time also increases. Okay. So von Willebrand disease is mainly occurs because of the deficiency of von Willebrand factor. Another case, a patient comes to a doctor with complaints of yellow coloration of the sclera and skin. The stool was pale or clay colored, bulky and foul smelling. He also developed itching and loss of appetite. Okay, so probably this person is suffering from the jaundice because of the yellow discoloration of the skin. Okay, and based on the stool color, uh, since the stool color is pale or clay colored and bulky and foul smelling, the probable diagnosis is there is a obstructive jaundice. Okay, so because of the obstruction, the bilirubin is not reaching the gastrointestinal system, and it is not being converted into stercobilinogen. So that is why stool color is pale or clay colored. And the bulky and foul smelling, it is mainly because of the malabsorption of the fat. Okay, and the itching is mainly because of the presence of bilirubin. On examination, pulse was 60 per minute. Sclera, mucous membrane were yellowish. Investigation showed the stercobilinogen was absent. Okay, so that tells that the type of the jaundice he is suffering, that is obstructive jaundice. There is a presence of bilirubin in the urine. Normally, bilirubin, if it is unconjugated, it is not excreted in the urine. But since the bilirubin in the obstructive jaundice, it is conjugated type, it appears in the urine. Okay, and the blood profile, there is involvement of the uh, the coagulation time is prolonged, so that occurs uh, probably because of the involvement of the liver. Then serum bilirubin is 6 milligrams per deciliter, and uh, Vandenberg test is direct positive. So Vandenberg test is directly positive because of the presence of conjugated bilirubin here. So the diagnosis in this case, it is very direct that the person is suffering from the jaundice and he is suffering from obstructive jaundice. Why the stool was pale, bulky, and false billing, as explained, because of the obstruction, the bilirubin is not reaching the gastrointestinal tract. So that is why the stool color is pale uh, and and it is bulky and false billing because of the malabsorption of the fat. Okay, so why Vandenberg test is direct positive? Because uh, in this jaundice you have more of conjugated bilirubin than unconjugated bilirubin, so that is why the Vanden Vandenberg test is direct positive. Another case, a 34-year patient comes to a doctor with complaints of yellow discoloration of the sclera and skin, and another case of jaundice, easy fatigability, and also has developed loss of appetite. On examination, pulse is 100 per minute, sclera mucous membrane yellowish, spleen was palpable, so that again suggests there is hemolytic uh, disease. The excess of the RBCs are being destroyed here, so that is why spleen is palpable. The hemoglobin is 7 gram percent. Stool stercobilinogen is present, uh, and urine bilirubin is absent. Uh, the coagulation profile is normal. There is no increase in clotting time. The serum bilirubin is 4 milligram percent per deciliter, and Vandenberg test is indirect positive. All the clinical symptoms and the investigation suggest of the presence of the hemolytic anemia, uh, which is leading to a jaundice. Okay, so which is also called as prehepatic jaundice. Okay, so the diagnosis is obviously the jaundice because secondary to the hemolysis, and the cause of splenomegaly is, as I told, so because the RBCs are excessively destroyed, so that is why there is a splenomegaly. The Vandenberg test is indirect positive because of the presence of most unconjugated bilirubin. So upon addition of the alcohol, so there is a change in the color of Vandenberg test, so which is called as indirect uh, positive test. Okay, so this mainly occurs because of the presence of uh, the unconjugated bilirubin than conjugated bilirubin. Okay, so these are some of the factors which are going to differentiate between the hemolytic, hepatocellular, and the obstructive jaundice. The urine color is uh, very high in cholestatic jaundice, that is obstructive jaundice. The the stool color is pale in cholestatic jaundice. It is dark in hepatocellular, normal in hemolytic jaundice. Okay. So the pruritus is commonly seen in the cholestatic or obstructive jaundice. Uh, in hemolytic jaundice, there is a history of anemia and uh, and the requirement of the blood transfusion. Whereas hepatocellular jaundice, they have a history with the contact of jaundice patient, uh, and in cholestatic jaundice, there is a history of the gallstones or biliary surgery. Okay, So urine bilinogen is present in hemolytic jaundice and it is absent in the uh, obstructive jaundice, whereas serum bilirubin is very high in obstructive jaundice, and serum transaminases are very high in hepatocellular jaundice, whereas alkaline phosphatase is high in case of the obstructive jaundice. And ultrasonogram shows hepatosplenomegaly in hemolytic disease, whereas there'll be dilated ducts of the liver because of the gallstone in case of obstructive jaundice. So these are the some of the case histories which are commonly asked uh, in the exams from the blood chapter. Thank you.